historically, I would say probably about 20 years ago, we had all GP referrals coming through the ED front door. We had very, very ad hoc communication systems between primary and secondary care. And as time went by, as people in the audience probably are familiar with, the demand increased more and more on our emergency department services. So in Gloucestershire, we realised that we needed to do something about it. With some funding from NHS England, we did some research as to what communication platforms were available out in the system, and we came across Cinapsis. And actually, Gloucestershire has been the first CCG to commission Cinapsis, and that was back in 2018. Since then, we have completely transformed and are continuing to transform our primary and secondary care interface, insofar as our patients now are able to be directed to assessment units, outpatient departments. They go in perhaps the next day, and a lot of them are bypassing the ED completely. So much, much better patient experience. From an acute physician perspective, it's a win because they have control over their patients. They know where the patient is going and where they can see them. And for the GP perspective, they're getting more and more confidence in managing their patients in this way. That is just a general overview of where we are in Gloucestershire at the moment.
Brilliant, thank you. That's really useful, actually, because I think it shows you the range of different services you have to coordinate, really, and for system users all across the pathway to understand it's obviously a complex system, as with any system, and it's really hard to remember the different there are, as you said, all the different community providers and all the different pathways that there are in place, and keeping up to date with that is very tricky, and all the different referral methods. So that's been really useful. So I suppose, what drove you to commission Cinapsis and SHREWD in the first place, and then obviously ask for us to integrate?
Good afternoon. I think, as with all these things, it takes something to start with. You need to drive for the reason for commissioning something in the first place. And so for us, the requirement was we have to, every CCG has to produce a OPAL every day, an escalation level for what you are as a system across your CCG patch. So for Gloucestershire, we need our OPAL every day for how the health services are doing, not just the acute providers, but 111, 999, community, primary care, everywhere. So when we came to looking for a system that could help provide this, because it has to be based on data and measures, and you need a system that can do that for you. So when we came to commission it, we found SHREWD, which has been really, really positive for our system. It was very much, I think, as Lisa said earlier, it's so visual. So it gives us that OPAL level that we need. So it takes the data and it uses algorithms to produce it, and it can be molded around what we need and what we think is right. But it's also the fact that it's just so visual. You can take one look at it and go, oh, we're having this kind of day. We're having a good day, a bad day, a level 3 day, a level 2 day. You can see it so easily. So on the very front level, you've got that. The sort of secondary level is because it's live data. So we've used systems in the past that have been updated once a day in the morning, so you could get your level for that morning, whereas we now know throughout the day what level we're at, so it can change at any moment. And you can see right now we've got this in ED, we've got this in 999, we can see this in the community. So the fact that it's like some of them are every 15 minutes, so that gives you a real feel for where we are right now as the system. But it also works with manual updates. So not all providers are quite there yet, that is fine. But SHREWD means that you can do them both. So you can have that live feed where once it's set up, the provider never has to think about it again, and it just feeds through all the time. But other ones are people have to manually put the data in, and it works with both of those. So combining the two together worked really well for making sure all of our providers could participate and we could get a good feel for the system.
I think the most recent integration has been extremely helpful. I think I would describe it as anytime, any place, anywhere as far as accessibility to the integrated system here. Before we had the integration, I had to go onto my laptop and log into Cinapsis, which didn't take a huge amount of time, But I then had to look to see how performance and activity was carrying on during the day. And I could have missed an opportunity. I could have missed some missed calls. But with the telephone system, I've got SHREWD and Cinapsis on SHREWD. I can see at any time of day. It's real time, as you said in your presentation. And if there's anything that I'm concerned about, I can then go and dig a little bit deeper. And I'll give you an example of this. On Monday, I was looking at the data on my phone, and I could see some of the calls weren't connecting to acute medicine. So I looked on the system, and I could see up to 12 calls hadn't connected. So I was able then to ring directly the rota manager in the hospital and alert her to say that this was happening. She then informed me that there had been a change in the rota management and that they'd lost some support with specialist registrars, and therefore there wasn't so much capacity on the rota. She was able to address that immediately, and then for the rest of the week now we haven't had any serious problems. So it's certainly helped from an operational perspective for helping with rota management for general managers and operational managers. And although I work in the CCG and I'm a commissioner, I'm hoping to devolve some of this responsibility now into the acute hospitals so that they take responsibility for their individual services.
Some other attendees as well. They're asking if data can be pulled from System 1, and I guess that goes across both of the platforms for Cinapsis and SHREWD.
Yeah, so just on Cinapsis, so we have the ability to pull clinical data from System 1, and we're kind of working out some of the power of that, you know, how that can make the referral process quicker for the GP or whoever else. But yeah, we have the ability to pull clinical information directly from System 1 and EMIS as well. I don't know whether Lisa, you pull data from System 5?
Not in Gloucestershire, but in other areas we have the ability. We've pulled in MIU data, and it's live up every 5 minutes. And I can't answer the tech question on that. It's something to do with a mesh engine, but we have got proof of concept of where we have done that for live data, and it's currently live now in a couple of areas.
Next question: what happens if a paramedic, 111 pathway, CAS clinician, or an out-of-hours clinician are not able to speak to a clinician straight away? Is there a time window for a response?
Yeah, so Helen can speak to this as well, but we've done a huge amount of work really with Gloucestershire to give a very good experience to that person who wants advice. And now our connection rate first time is 93%. So that means that within about 60 seconds, you have 93% chance of being connected to a specialist, and that's across the board, all specialities. So if you've got 93% one time, all you have to do with Cinapsis is a single click again, and you can try again. So you can see that the connection, the chance of connecting in a very short period of time is very quick. The other thing is that we give full visibility to the GP of what's happening. So how many, acute medics or pediatricians are available right now? How many were called? What happened to each call? So where did they go? Were they not answered, or did they go to the answer phone? So there's real visibility to that GP. And also we support other communication channels like callback. So really that clinician who wants advice, they can make a decision about what to do, what's appropriate for them, try again, or request a callback. So there's a lot of other things like automatic alarms if there's any gap in the rota. So all these things have really pushed the connection rate, as I said, now to 93%. Helen, do you want to say more about that?
Yeah, I just want to echo that. I think one thing that we pride ourselves upon is the work that we have done to ensure that we give good customer service, not only to our referrers, but also to our clinicians who are answering the call. When we implemented the system, we didn't mandate much, but one thing we said to our acute medical clinicians was, you have to answer the phone, and you have to answer it in a timely way. And we almost worked out the number of rings that they needed to ring to answer it by, and it was about 5 or 6. And in way, if the referrer gets a prompt response, they are more likely to continue using the service. And as Owain said from his results there, we're at 93% for first-time calls. The clinicians, the referrers often try second time, and I think our connection rate is above 95% for that. And that is exceptional. And we set our KPI at 90%, so we're exceeding that, and we're consistently exceeding that. And I know compared to other providers, we are streets ahead. So I think that is testament to the hard work we put in when we set it up right at the beginning.
Great, thank you so much. Another question here with relation to the visibility of ED, being able to see the pressure, and the question stems from that with, are you able to directly book patients into ED slots or SDE slots, EC slots, sorry, as per the Think 111 First and the new IEC KPIs?
Yeah, so this is a direction of travel, really. So we are with our for example, with our partners in EMIS and their some of their systems that they have, such as Symphony, that is kind of a direction of travel for us, is to be integrating with systems that can directly book. So that's really exciting. So not only, so we think there's two components to it. One part is the advice. The second part is administrating that advice and, you know, facilitating direct booking, like we're doing with ERS integration. You know, for elective care now, we can take advantage of booking technology that's been developed and robust and can communicate with patients. But this is part of the direction of travel, and we're talking to, you know, to a number of providers of booking, so not just EMIS but also you know, Vital Hub as well. So it's a number of providers to get that functionality absolutely right.
Following a Cinapsis call, how is the outcome documented? Is it completed by the referrer on the system and uploaded to the relevant systems?
Yeah, there's an outcome that's completed by the specialist, so whoever that is, a pediatrician or trauma orthopedic specialist or acute medic or whatever. So they record they select an outcome, so where the patient should go, and explain their reason for that. And then that is sent then wherever it needs to go. So it's sent to the appropriate GP practice, so you consolidate with the primary care record. It also can now be sent into the secondary care record as well, you know, via a HL7 integration engine that we have. But also it's communicated to the team. So if you're the medical registrar on call, you can have a patient list. So you know this patient is expected in A&E or is expected in the SDEC unit.